Good morning. Today for Grand Rounds, we have the UC Davis Department of Surgery John M. Mott Jr. Lectureship and the honor of welcoming our guest today, Dr. Ara Vaporciyan. First of all, I would like to thank the Mott family for this wonderful opportunity. John M. Mott Jr. was a general surgeon and extraordinary leader in the greater Sacramento metropolitan area. Dr. Mott was instrumental in creating the UC Davis School of Medicine. In addition, Dr. Mott was also influential in starting the Kaiser Hospital in Sacramento and served as his physician-in-chief. His wife, Ann Mott, provided funds to the Department of Surgery in his memory to support a visiting professor lectureship. His son, John M. Mott III, MD, is an anesthesiologist in Helena, Montana, and completed his residency at UC Davis in 1984, and was on the UC Davis faculty for 10 years. So again, let's sort of give a round of applause for the Mott family for providing this opportunity. So, Ara Vaporciyan is a professor of surgery and chairman of the Department of Thoracic and Cardiovascular Surgery at the University of Texas MD Anderson Cancer Center in Houston, Texas. He began his training as an undergraduate and then a medical student at the University of Michigan. Dr. Vaporciyan completed his general surgery residency at the University of Texas Houston Health Sciences Center, where he served as Dr. Kokenauer's intern. So there's a lot of coffee-getting stories and other things. He then did a CT surgery fellowship at MD Anderson, where he stayed on as faculty and currently serves as not only chair, but also program director for the CT surgery fellowship. Recently, Dr. Vaporciyan has focused his academic interests on medical education. In fact, he is the face of an ongoing complete overhaul of cardiothoracic surgical education in the United States. He obtained a master's degree in health professions education through the University of Illinois Chicago. His research interests now involve the role of simulation in education, faculty development, and the integration of novel online teaching techniques in cardiothoracic surgery. His efforts have resulted in the first online learning platform that currently is the National Cardiothoracic Surgical Curriculum for all North American trainees. Dr. Vaporciyan has hit the CT surgery education trifecta, currently serving as Secretary-Treasurer of the Thoracic Surgery Directors Association, a Director of the American Board of Thoracic Surgery, and Chair of the ACGME Thoracic Surgery Review Committee. Please help me thank Dr. Vaporciyan for being the 2017 John M. Mott Jr. Lecturer, presenting his lecture entitled Modernizing Pedagogy and Cardiothoracic Surgical Training.
That word always gets everybody, pedagogy. So I have no disclosures. So just to get started, I am not here to denigrate our model of education. This is the model of education for surgical training that has existed for over 100 years. All right, this is the apprenticeship model. And it's an old and stable model of training technical skill. It was built and founded really by the guilds over 1,000 years ago. And it was perfected and brought to America from France. And has really been our model of surgical training now for over 100 years. And I'm not going to attack this because it does work. What it takes to work is these three things, plus some other things that were added in time. First and foremost, you need dedicated teaching faculty. Just like in a guild, you need somebody who's going to take you under their wing and work with you and train you. For example, Ben Franklin was in a guild for printers, and it took him 7 years as a trainee in his guild to finally become a master printer. Interesting, that's how long it took me to become a cardiothoracic surgeon. But what you need is dedicated teaching faculty. In addition to that, you need an abundance of clinical material. You need to be able to see all the different ways patients can present and be able to practice with those patients underneath the watchful eye of your teaching faculty. And then the third thing you need is adequate time. You can't rush this because there's a lot of nuances that are going to be taught over and over again. And so those three things interact. What the guilds added and what the boards have added is that national organizational oversight to ensure that everybody's doing it at least the same way and that the final product that comes out under all this apprenticeship is similar no matter where you train. The order in which it's done and the methods that are employed at each institution are irrelevant as long as the final product meets what the National Organizational Oversight feels is the definition of a graduate. And while we've been doing this for 100 years, we never really thought that there was a science behind it. But if you read this book by Benedict Carey, where he describes sort of modern educational principles, you start to realize that a lot of what we do in Apprenticeship Model is based on real science of education. And this book is a wonderful book that reviews some of the modern advances that we now understand about how people learn and how people retain knowledge. But three of them came out to me as three things that we do routinely in an apprentice training program like what we've been doing for the last 100 years. The first one is what's called spacing out. And it doesn't mean what your kids would say about spacing out. It actually has to do with the idea of putting large gaps between learning the same information. Rather than concentrating your time on one area and then moving on to the next one and never going back, what research has shown is that if you study a thing for a little while, then leave it alone, then come back, the more frequently you do that and the longer gaps between you going back and forth to the same material, the greater the retention of the information. The other one is called fluency bias, and I'll talk a little bit more about that later, but essentially that's the idea that quizzing and testing is actually an extremely efficient way to learn information. And the whole concept of pimping and rounds and what we did in the apprenticeship model actually makes a lot of sense and helps not only get the knowledge in, but it helps with the retention. And then the last one is what's called interleaving. And this one came with an example which I thought was wonderful. They took a group of students and they had them practice intensely on throwing a beanbag toss to a target that was 4 feet away. And they got to practice for an hour a day for like 3 days in a row just at the 4-foot target. A second group of students was told to practice interleaving a 5-foot target and a 3-foot target. They never threw the beanbag at a 4-foot target. After both groups had finished practicing in that manner, they brought them both back. They put a board in front of them so they couldn't see the target. The target was 4 feet away. The group that had practiced on a 4-foot target for 3 days did worse than the group that had practiced at the 5-foot and the 3-foot target, having never thrown a beanbag at a 4-foot target. That's because the idea of seeing things differently is much better than seeing it the same way every time. And that, again, is something we do. Every patient is different than walks into clinic. We don't get the luck of having a stage 1 lung cancer day where everybody walks into the door is a stage 1. No, we see a stage 2, we see a stage 4, we see a stage 1, and we'll throw in esophageal cancer. Our clinics are mixed, as are the way patients walk into the emergency center. And that mixture of content actually is much better than focusing just on one skill over and over again. So why would I talk about modernizing this? This clearly works. It's been working for 100 years. Well, the reason I talk about modernizing is because it's being threatened. Not the actual idea of how it works, but our ability to do it effectively. And these 4 threats are the ones that really pop out whenever you talk to anybody in surgical training or in medical training for that matter. The biggest one probably for sure is the competition for time. Now everybody argues duty hour restrictions and all that sort of stuff. I'm not talking about duty hour restrictions. I'm talking about everybody's time. The faculty are busier. The faculty have RVU targets. They are expected to produce more to get less. In addition, there is enormous increases in regulatory and documentation. We now have studies that show 40% of our time is spent in front of our electronic health record, documenting and adding coding and these sorts of things. All that erodes the ability for the teacher to stay in contact with the trainee, and similarly for the trainee to spend time reflecting on the case. The other one is an increasing focus on outcomes. Obviously, that's not a bad thing. We should focus on outcomes. But the problem is when you focus on outcomes to the extent that you can't allow anyone to make a mistake anymore, even a small one, even one that can be easily recovered and doesn't touch the patient. Those sorts of errors were what I trained on. That's what a county hospital let us do. We would do those errors in a protected, safe environment. We would learn from them. That's gone. There is increasing case complexity. I mean, a trauma patient with a mitral annuloplasty, a maze procedure, a pacemaker, I mean, that's pretty complex. But similarly, all the easy stuff, if you look in cardiac surgery and in general surgery, you'll see that the simpler cases are having other techniques that take them away from the trainee, and so you don't get that continuum of case complexity. What was great is we still had complex cases 20, 30 years ago, but we also had the easy ones. And so you could cut your teeth on the easier ones and then move slowly to the more advanced cases. We can't do that anymore. The cases are more and more dominantly complex when they walk through the door. And then this is probably the biggest one and the hardest one to wrap our head around, but there is a massive increase in knowledge. It's coming faster and increasing faster than it ever has before in time. And I'll talk a little bit more about that as we go on as well. In addition, there's two other factors that have come into play. And if you like medical education history, this is an author, Kenneth Ludmer, he's written 3 books now on it. This one, Time to Heal, talks about the sort of evolution of medical education in the United States. He starts right after Abraham Flexner wrote the Flexner Report. And what he showed was prior to Flexner's report, medical schools were predominantly proprietary. That meant you could be milking a cow one morning, and that afternoon you could be in medical school. All you needed to do was pay the tuition. There was no entrance exam, there was no qualifications, there was no bar being set for who gets in and who doesn't get in. You pay the fee, you're a medical student, and 2 years later you're a doctor. No hands down. Well, when Flexner came around and exposed all this, he shut down 2/3 of the medical schools in the country. He annihilated them. And what was left after that were really schools that focused purely on education. These were schools like Hopkins, Michigan, and what happened there is education became the absolute primary goal of these institutions. In fact, clinical material was only included into the hospital's repertoire if it fed the educational need of the trainees. They never did cases purely for revenue, or they never did cases where there wasn't an educational value to the trainee. And that was the existing design up until around the 50s. And then what happened? In the 50s, suddenly society, and more importantly the government, got wind of all the amazing things medicine was starting to be able to accomplish. We had transplantation, we had cardiopulmonary bypass, we had antibiotics, we had unbelievable advances in medicine that held the promise of curing and improving the lives of everybody in the United States. And suddenly the government, hearing the onslaught of the public's desire for this, pumped massive amounts of money into academic medical centers in the forms of grants. It was easy to get a grant. 2-page paper. There were cardiac surgeons, Kantrowitz, with multiple R01s simultaneously while being a busy cardiac surgeon in Maimonides in New York. You could get money hand over foot. And over those next 2 decades, medical centers swelled. Budgets went from the tens of millions to the billion-dollar budgets. And it was not uncommon to see these massive medical schools. And what happened is research became the primary focus of academic medical centers. And education, while still important, moved down one rung in the ladder. Then you move on to the 80s. We get a couple of recessions. There's an oil crisis. Suddenly the cost of healthcare is going way up. And what happens now is the grants dry up. Governments don't have that much money. And these medical centers that are running on $1 and $1.5 billion budgets realize that they need revenue to feed that machine that they've built over the last 3 decades. And so what they turn to is their ability to provide clinical care. And they start leveraging clinical care as a revenue engine. These are the decades where you see a massive rise in the number of faculty at academic medical centers. There's a huge increase in the number of faculty being hired, but they're not being hired to teach, and they're not being hired to do research. They're being hired to do clinical care so that they can leverage the revenue from those dollars. Research is still important because it still does generate some revenue, and education drops further, one more rung down the ladder. On top of all this, there was a slow change in the culture of the public. Back in the 1920s, the public understood that they played a role in the education of trainees when they came to government or academic medical centers. They understood that they would be cared for by a house staff because they would help that house staff's training, and that house staff would graduate and go out into the public sector and take care of their children. Over the last 100 years, that trust of the public in the medical system and their willingness to participate in our educational system is gone. It no longer exists. The public will not accept being trained by some, or being cared for by someone other than the attending faculty. And that is ubiquitous across not only the United States, but the world, I would say. So these four things: competition for time, increasing focus, increasing complexity, and the rapid expanding body of knowledge, we'd like to think that they're our sole property, but they're not. They have been in existence for decades and decades in K through 12 education. So if we're going to look for a solution, a sensible idea would be to look at what K-12 education has done to address these exact same problems. And they have them like in crazy amounts, right? This is the competition for time that K-12 education is dealing with, right? It is harder and harder. It is easier and easier, for students to be distracted from what they do at school. In addition to that, we've tried the increasing focus on outcomes, all right? The No Child Left Behind program was a massive increase in the amount of assessments that are provided of children. And then this is the one about the rapidly expanding body of knowledge. What I graphed here is the average age, or is not the average age, it is the age of a Nobel laureate per year in the major disciplines of chemistry, physics, medicine, and literature. And what you see is, since the Nobel was awarded, the age of the Nobel laureates has been increasing. And what researchers feel is the cause for this is that the body of knowledge that someone has to wrap their head around before they can start breaking through that upper barrier of what we know, which is what is necessary to win a Nobel, is getting larger and larger. And so it's harder and harder to do it at the age of 45 or 50, because you really haven't mastered the body of knowledge till you're now 60, 70, even 80 years old. And so that's massive amount of knowledge is being pushed down across K through 12, and they've been dealing with it for quite some time now. This is probably the solution that will be the future for them. Who knows who Clayton Christensen is? Wrote a very famous book, Innovator's Dilemma. Anybody ever heard of that book? So Innovator's Dilemma is the idea that disruptive technology can come in and upend what otherwise somebody thinks is a perfect business model. You got a product, it's working great, you're making it better for your customer, you keep tweaking it, you keep adding bells and whistles to it, your customers love it. A new product comes around that's totally different and totally disruptive. The vast majority of your clients would never jump ship to that product. But there's a small cadre who find benefit in the new product. That's enough for the new product to continue to undergo improvement slowly and steadily until finally that new product is as good or better than the existing one your company has been working on for the last 2 decades. And suddenly you watch in horror as all your customers jump ship and go to this new technology. And that sort of disruptive technology Clayton Christensen described in the Innovator's Dilemma, and he is calling that same process going on in education with computers. And he makes a very strong argument for how that's happening in K-12 education. And it's going on across the globe. And we've seen that in medicine. Disruptive technology for the cardiac surgeons is stenting. I was at Michigan as a medical student when Eric Topol did the first angioplasty there. It was a 6-hour ordeal. The patient got a groin hematoma. The case he was doing it on was a bilateral amputee who had prior bypass surgery. It was crazy. Nobody thought it was worth anybody's time. Fast forward 20 years, and now that's the dominant form of treatment, all right? That was disruptive at that point. And this is what Christensen is saying about computers in education. Who knows who this guy is? Anybody? He's on a $1 trillion Forbes magazine. Somebody said it, yeah. So this is Khan, Salman Khan, Sal Khan. Does anybody know Khan Academy? So Khan Academy, Sal Khan didn't invent the idea of computers in education, nor did he perfect the idea of flipping the classroom, which is what he's employing. But Sal Khan certainly brought it into light. Sal Khan is a hedge fund manager. He likes to say he's a recovering hedge fund manager in Boston, whose niece lived in New Orleans and was entering high school math and was having a very difficult time of it, like most students do as they make the transition from elementary school to high school level math. And so Khan started tutoring her by phone. But the schedules got difficult, it got too hard, and so he started making video lessons. There was really not very great technology to share video lessons, so he put them on YouTube for his niece to view. And what he soon found out was that his niece preferred the video version of Sal Khan than the live version of Sal Khan. And in fact, thousands of people started emailing him saying they also preferred the video version of Sal Khan. So Sal created a whole series of videos covering small topics that he put out on the line. He created the Khan Academy. And as I said, he didn't invent this idea of flipping. Flipping was invented by others. He just took it to the next level and employed it in school training in elementary. Anybody who says that education is not a laudable academic path, I'll just point out where this article is published. And I'll challenge people in the audience to see how many science publications they have, all right? This is an article that really put the nail in the coffin for anybody who is an opponent of flipped classroom design. What flipped classroom says is the normal classroom is what's going on here. I'm the lecturer, you're the students, I spit out knowledge to you, when I'm done, we walk away. But what that fails to do is it doesn't take advantage of my ability to teach you how to apply the knowledge that I have. And what flipping says is, what if the lecture took place at home and the classroom was where you practiced it? And so what they took in this study is they took the best physics professor at an introductory physics course in a university. And this guy's teaching a class of 200 kids. And he is the one that wins the teaching award every year, hands down. Man, he's a fantastic lecturer. He's engaging. He does examples up at the front of the room. Wonderful lecturer. And they asked him to teach, in his personal style, a short section of the physics class that usually is covered in 3 lectures, 1 week, Monday, Wednesday, Friday, it's done. Except this time they gave the kids a pre-test before, they gave them a post-test afterwards. And this guy went at it, he did his magic, he taught the course. And the next semester they took another group of 200 kids, and this time they put a TA in the front of the room. This guy had never taught a lecture bigger than a small group discussion with about 10 kids in it. This guy was not a physics professor. It was just a simple teaching assistant. But they provided him the tools to do a flipped classroom methodology. Same thing, he taught his 3 courses, but instead of lecturing, he worked with the students on problems. And he took better students and put them with weaker students and got them to work together. And the entire hour of the lecture was spent practicing the problems that the students had listened to at home online on a lecture and taken a small quiz to prove that they actually listened to the lecture. And when the pre-test, post-test of that portion of the experiment was compared to the pre-test, post-test, there was absolutely no comparison. The TA, is the black bars here, blew away the best professor at the institution for lecturing. And this methodology of flipping the classroom is what Sal Khan imposed and used, and now is being picked up all over the place. Well, I would make the argument that surgical training is absolutely primed for a flipped classroom methodology. What our current model is this. We have knowledge and facts, we dump those into the trainees, and then we show them how to apply those knowledge and facts on a day-to-day basis when they're caring for a patient. And this is unfortunately where we spend a lot of our time, getting that knowledge and facts in, because it's easier to do, right? It's easy to pimp on knowledge. You know, it's easy to pimp on anatomy. It's easy to pimp on what antibiotics you would use. It's harder to apply. To teach people how to apply is harder. Well, what's been going on is that the amount of knowledge and facts has increased massively. And the other thing that's going on is that little green arrow has gotten smaller and smaller because there's less and less time available for the teaching faculty. So what if we move the teachers down here to do the harder part, to teach students how to apply the knowledge and use it in day-to-day practice, how to do the case? And that's what Sal really said. Sal said, he said, it was never my vision that watching computer videos would be the entire method by which students would learn. He was just interested in producing a system that would make education more efficient. And where would I think that e-learning would work? Well, 2 areas. I think that e-learning could help our residents on the organization and delivery of knowledge. And second, on the formative assessment of knowledge. And that's formative. That means assessment for learning, not assessment of learning. That's a summative exam. That's a board exam. This is about how you take assessments to help you learn faster, better, and with better retention. And what type of knowledge am I talking about? Educators love pyramids. That's something I learned going through my master's. And this is a taxonomy called Bloom's taxonomy of knowledge. It sort of hierarchically places different types of knowledge. And what you see at the bottom is kind of the easy stuff. Remembering and understanding, that's easy to do. But then as you go up the pyramid, you see you get to more and more complex forms of knowledge. Creating something, evaluating something, analyzing something, that's much harder to do than simply memorizing a fact. And so where I think we should apply e-learning is down here at the bottom on understanding and remembering, because that's the low-hanging fruit. If we can get that done, we can offload a tremendous amount of time from the teachers and let them focus that time now on the harder stuff, the creating and the analyzing and the evaluating. Well, why is organization and delivery the first one so important? And I got a little exercise, and we're just going to split the room here if I can. So there's these three of you right here. You will be on that side of the room. Everybody else is on this side. So why don't we start by this side of the room. Look down at the table, please. It's the honesty program here. Do not look at the screen, all right? This side, you guys get 10 seconds, all right? Take a look at this. Oh, I'm sorry. Never mind. I changed the order of my slides. Oops. Why is organization and delivery important? Because this is the classic model by which people get their information now, all right? We used to have textbooks. We still do have textbooks, but studies have shown that medical students, for sure, will go to Google first as their first primary source of knowledge acquisition. And that's kind of embarrassing for any professional society to hand over the educational aspect of their profession to Google and algorithms. And this is the problem with it. These are the total citations in Medline, which I plotted here. And I got up to about 2012. If you get to 2017, there's over 25 million citations in Medline alone. That's just one form of knowledge. Never mind all the videos that are out there. Never mind all the textbooks. Never mind the journals that are not peer-reviewed and placed in Medline. This is a massive fire hose of knowledge that is being dumped into our trainees with no organization and no oversight. So now, why is organization important? All right, this side of the room, look down. This side of the room, you have 10 seconds. Memorize as many of these as you can. Okay, so the other side can put their head up. How many of you could get maybe 5 of those? That's not bad. How many could get about 8 of those? 1, brave, 2, brave. How many could get 10? Nobody. All right, this side of the room, heads down. Don't look. This side of the room, look at the screen. You have 10 seconds. Okay. How many in this room could memorize 5 of those? All of you. How many could memorize 8? All of you. How many could memorize 10, you think? At least half of you. Are they smarter than you? Because I showed them the same words.
More attendings.
More attendings over there. Actually, that's wrong. You guys do better than attendings do on factual stuff. This is the difference. All right? It's the same words. The only difference is I organize them differently. Organization is incredibly powerful. That's the role teachers have. It's not spoon feeding, all right? It's cutting through the clutter and making learning efficient. And organizing knowledge is an extremely powerful way to do that. What does that look like for education of residency? So this is an example I use. So let's say that this box right here contains all the knowledge that we want our graduates to have in, say, lung cancer care, in thoracic surgery, all right? So we'll just assume that that box. Now, there's going to be a lot more knowledge on lung cancer than we need our graduates to know. But we'll say that at the time of graduation, they better know everything that's in this box, all right? Well, there's probably an article that's great that covers one part of that. And then maybe another article over here, and then maybe a book chapter like this that unfortunately a lot of that book chapter is unnecessary. It's too detailed, but parts of it are really good. And then maybe there's another one over here and so on and so on. And what you end up getting is this enormous patchwork of content that's out there that is like that fire hose that covers this area. What organization and oversight would do is it would start peeling back those articles that really are not necessary or are duplicates, and really get it down to sort of the core articles that our trainees need to read, or the core video, or the core book chapter, whatever it is. It's our job as educators to do that. And then we could push that out to the trainees in a uniform manner as opposed to using Google. What about formative or self-assessment? Well, this is what currently exists for cardiothoracic surgical trainees, and I would have to say that that's embarrassing, because actually only one of these is formative. That's CSAT's 11, all right? The in-training exam is not very formative, meaning you can't really use it very well for education. It comes once a year. The feedback you get from it is pretty 35,000-foot view. It's not really down there at the granular level, so it's not very easy to implement it into your study. And the board is certainly a summative exam. It's all over by the time you sit for that. You're not going to be able to really use that, except if you fail. There's also this, obviously. This is the bedside formative assessments by the faculty, or in the operating room where we quiz you and we pimp you. But as I said before, wow, that's getting harder and harder. There's a lot of competition for time. And also, as I said before, wouldn't it make more sense to use that valuable time on the harder stuff and not on the easy stuff, the understanding and the remembering? And so why is testing important? I talked to you about this again, about the fluency bias earlier. So I'll ask everybody a question. Just don't think about this too hard. Just give me the answer. So how many animals of each kind did Moses take on the ark? Just hold it up in the air. How many do you think? Two, right? Yeah, except Moses didn't build the ark. Noah did. All right? So that's called fluency bias, all right? You jump to the answer because it made sense to you and you heard it. Just like our resident jumps to the answer when we're in the operating room with a patient and we say, what do you want to do for this patient? And the case is already booked for a lobectomy. Resident's not dumb. They're like, well, I would take this patient to the operating room and do a lobectomy. Wow, that's incredibly insightful of you. Unfortunately, you got caught by fluency bias, all right? And so how can you overcome this? Well, fluency bias, this is the definition, it can be overcome with testing. And here's another place where educational literature is a lot more academic than we think. These are multiple studies that have been done. And again, you can see that this one popped into Science here, the last one, where they have shown that not only is testing important to learning, but it far outperforms studying. In the study on the left, the 3 bar graphs show not only that there's there's equal learning when 3/4 of your time is spent testing yourself and only 1/4 of your time is spent studying. And the retention for that model far outweighs the individual who just spent the entire time studying. In addition, they've shown that testing overcomes the loss of retention that happens when you're under stress. So when you're operating room and things are going to hell, testing yourself during knowledge acquisition actually preserves your knowledge and doesn't let it erode under stress, which has commonly been shown over and over again in educational literature. So testing is a key method of not only learning, but of preserving that knowledge and retaining it. So we thought about 7 years ago, or 5, and I started thinking about this about 7, 8 years ago, how can we assist our trainees to learn basic knowledge more efficiently while simultaneously freeing up our educators to do what they do best, which is teaching at the higher levels of Bloom's taxonomy. And what we came up with at that first foray was using Moodle, which is modular object-oriented something. There'll be a quiz on that later. And then a little bit of money, not too much money, we weren't given a lot of money, and then many, many volunteer faculty across the country. This is what we built. We piloted it first on tracheal disease. We brought together about 5 or 6 faculty, and what we created were 4 courses. And we did that thing about the organization. We found the articles for each of these 4 courses. Each course came with the content and came with a bank of questions, about 60 questions. And the trainees were given the courses, told they could do it at any order they wanted, at any time they wanted. They could read the material, they could go straight to the quiz, they could do whatever they wanted. The quiz was randomized, so they take a 10-item quiz, and the next time they took that quiz, it would be a different 10 items, randomized from the question bank for that particular course. And they had to score a 90 on that quiz to pass that course. They could take the quiz as many times as they want. They had a 24-hour block, so they couldn't just take it in a row. They'd take the quiz, then they couldn't take it again for 24 hours. And what we found is it took roughly about 8 weeks for the trainees to get through these 4 courses, little by little. And what we saw when we looked at their first attempt on the quiz compared to their second attempt on the quiz compared to the third attempt was they were learning. But their scores on the quizzes went up. And remember, they're not seeing the same items each time. They're seeing a different item because there's 60 items. The average number of attempts it took to pass the course was about 2.4. And what we found was the higher level trainees did it faster than the lower level trainees, which you'd expect because they were already with some of that knowledge and they didn't need to learn as much. And so we said, wow, this actually works. They actually can do it on their own and they can gain some of this knowledge on their own. Now, none of these courses, as you saw, talked about how you apply that knowledge to actually treating a patient with a tracheal disease. That's done by the professor. But what we decided was we had enough evidence there to go live for the whole thing, and we were asked to create now a course for everything. Now, we couldn't make courses for everything because that was very labor intensive, so we just put the content out there and we put the quizzes out there, and we built this first system. It launched in August of 2013. We were getting about 290 logins per week for about 350 trainees in the country. And then when the subsequent year came out, that jumped up to nearly 500 logins per week. So everybody was logging in weekly and taking a look at this thing. Some people were logging in daily. It was being used. But Moodle has a bunch of limitations. First and foremost, it's open source, which means anybody can add code to it. And it's a massive program. It was created at MIT as a virtual classroom environment that could be downloaded by anybody. But it's got some problems. It's messy. It is not pretty, all right? It has limited national personalization and no personalization at the program level. So I, as a program director, couldn't make my site any different than anybody else's. It had to look exactly the same across everything. And as we talked about before, the apprenticeship model is what we call a multi-tenant environment. Everybody exists within this umbrella that the American Board of Thoracic Surgery has established, but nobody has to do it in the same order. And so to dictate on high just how the lessons were going to come and what order they were going to arrive was not ideal for our learning environment. In addition, it was designed around a classroom structure. There really wasn't an opportunity for students to create their own quizzes and quiz themselves whenever they wanted to. And we knew that that was going to be important. So we ditched Moodle and we went to a new platform with a company called Astute. And this one did cost us a little money, but Astute was eager to get involved. Astute is a massive company. They actually built the learning management system for ASCO. So if anybody knows ASCO, ASCO has more money than God, all right? They have billions of dollars. They could have gone anywhere. They went to these guys. So did the American College of Cardiology. Probably kind of more money than Jesus, I guess, or the other God, or whatever you want. They got a lot of money too. And then the American College of Radiology, which has a lot of data, obviously. So this company had a lot of experience building sites for companies with enormous amounts of cash revenue, but also with enormous amounts of data. And they were excited to get into the graduate medical education world, so they jumped in and they started helping us build this site, which we launched roughly a year ago. And one of the things that we were able to do on this next subsequent launch, this version 2.0, is we had now improved look with local institutional personalization. You can set up your curriculum at your site any way you want, in any order that you want. You can add and subtract courses. You can totally ditch the recommended national curriculum and set up your own. You can even upload your own content to it. If you think there's a better article than the editorial board created for these subjects, you are welcome to add that to your section and push that out to your trainees. In addition, we put a library in there. Moodle never had a library. We actually had to use a different program for our what's called content management. Now, Astute created a library and created a tagging system so we could link questions to content and link content to a search engine so that a trainee could search for content that they wanted. It's not robust yet, still needs work, but it's a start. The next thing we had was improved assessments. And not only did we provide assessments at the individual level, so a student can take a quiz and quickly see how they did, much like a CSATs quiz. They can build that quiz to touch on any subject they want. But in addition, we created benchmark quizzes. These are quizzes at a course level, so covering all of ischemic heart disease or all of lung cancer. And these quizzes are in the same format for everyone who takes them across the country. And the minute you take it, you can compare your grade to everybody else in the country who took that quiz right now and see where you're at compared to them. So it gives you some feedback of how you're progressing compared to all your colleagues across the country. And not just across all residents in cardiothoracic surgery, but we'll also allow you to focus down on trainees in your same type of training program, so a 2-year or an I-6, and then even further at the same postgraduate level that you're at in your training program. So if you're a PGY 7 in a 3-year traditional program, you can see how you scored on that test compared to all the other PGY 7 traditional 3 years. We also have some planned improvements that are going on right now. First one is this one, automated assessment directed assignments. This is already in place in high school and in elementary school, but the idea is here. Let's say you create a quiz that's got some lung cancer in it, a little stuff about lung metastases, a little stuff about benign lung disease, and you take the quiz. The system will analyze how you did, and it'll say, okay, you did not do so well in benign lung disease. Here are some reading assignments for you. You need to read the following areas. With really good tagging, which is what we're doing with all of our content, we'll be able to do this. And this technology exists today. It's just a simple matter of integrating into the system and having robust enough content that's tagged well enough and enough items in the quiz bank to be able to do this reliably. The other one is updating content in near real time. And this is what I talked about at the very beginning, the idea of this rapidly expanding body of knowledge. This is utility patents offered in the United States since the patent office opened. This is what it looks like. All right? This is actually moving like Moore's law. Who knows Moore's law? Right? So Moore's law is the law of, Moore was one of the co-founders of Intel, and he said that the processing speed on a chip will double roughly every 18 months. All right? When you start looking at innovation in general, it's doubling at that pace, roughly about every 18 months to 2 years. And it doesn't matter what you look at. If you look at, for example, the speed at which humans can move from place to place. When we first started, we walked. When we invented the wheel, we got a little faster. Then we started riding horses. Then we had cars. Then we had jets. Then we had rockets. If you look at the speed at which mankind has traveled over the face of the earth, it's also moving, similar to Moore's law. And this is what that looks like in the knowledge realm. Let's say that this box has the editorially vetted content that a trainee must learn for aortic valve disease care. All right? Well, all of a sudden an article appears over here on TAVR. All right? And then another one. And then another one. All right? And all of a sudden, the editors are seeing a whole host of articles on a new subject that wasn't included. All right? Now, we could wait till the textbook comes out. But what would be better is if we could quickly redesign the content that they need to know and what articles will be included and push that out to the trainee in real time or in near real time. John Leanhart, he does Engines of Our Ingenuity on NPR. If you ever listen to that radio program, it's usually on in the mornings. He also wrote a book called How Invention Begins. And he talks about this. He talks about it with Gutenberg. He says that when Gutenberg first produced the first book in 1450, there were only 1 million books on the entire face of the planet. Within 50 years, there were 50 million books on the face of the planet. That massive expansion in knowledge availability to common people launched massive revolutions. The entire Reformation of the church was launched through printing and the availability of the Bible that went out. what Lienhardt says in this book is it took hundreds of years for the impact of publishing to become recognized. Even when you think of people who are consummately associated with an invention, say the Wright brothers, everybody can look at the Wright brothers and say they invented powered flight. They are the ones. In actuality, they didn't invent any of the components that went into their powered flight. They just assembled them and brought them together. They didn't build an aluminum engine. Somebody else built that. They didn't build a wind foil. They did perfect it. They didn't build the propeller. Somebody else built that. They simply perfected it, all right? And they got all their information not through areas of higher learning like college, because neither of them attended college. They got it through books. 300 years after Gutenberg started this process, you were still seeing the impact of books on invention. The internet's been around for about 20 years. The impact it will have on the dissemination of knowledge will not be realized for another 100 years at least, but it's already massive. It's already changing the face of the planet because suddenly we've democratized at a logarithmic scale knowledge that we've never done before. How can you leverage that democratization of knowledge? Who knows what Encarta is? Yeah, not such a great move, right? Yeah. That was their attempt at a online encyclopedia. Well, it failed. It was obliterated by this one, right? Everybody knows Wikipedia. Has anybody ever been to this site? Let's see if it runs. It may take a second. There it is. Anybody ever been to this site? This is edits occurring to Wikipedia in real time as we sit here. Each fold that appears is sized relative to the size of the edit. That tone right there is a new member logging into Wikipedia for the first time. So if you listen to this, there are roughly 170 edits per minute taking place to Wikipedia around the planet. You can actually click on the name and go immediately to the edit in Wikipedia and see just what they did as they edited. But this is what's happening in real time around the planet. And it's actually kind of nice to listen to. It's got a zen there. Yeah, you can get lost in a residency program, sure. Everything. All right, so we'll turn that off promptly. All right, so this is what I'm thinking we can do. This was another idea we had. So the idea was, what if we took chapters in our textbooks, we updated them, and we posted them to our own wiki site. All right. Now, I'm not saying that every resident in every place in the country can edit these chapters. No, I think there needs to be editorial oversight. But what you could do then is you could collect comments from end users. As trainees, as students are using it, they could call to attention the fact that a new set of guidelines was just published, all right, in ACCP or in Annals or in JTCVS, and say, hey, I haven't included the new guidelines that just came out last week, all right? And what we would have is a central location that pulls these in, and when those comments cross a threshold, that would initiate a need for revisions. The chapters would be sent back out to their original authors or to new authors, revised, and then posted. In addition, any questions in our question bank that were tagged to that piece of comment would be sent to the author of that chapter as well to review the questions and make sure they're still up to snuff and they haven't become out of date. And this can happen in real time as opposed to waiting 5 years between edits of book chapters or books as you see right now. So a single chapter, hell, a single paragraph in a single chapter could be updated in near real time as opposed to waiting 4 or 5 years for the entire book to be re-edited. And we've already started this process. We were able to purchase Pearson's textbook of general thoracic surgery for 35 grand from the publisher because they narrow-mindedly did not want to produce another edition of this. All right. Once we got this, we handed it over to Gail Darling at Toronto. She is re-editing, along with all the original associate editors and new banks of authors, the chapters. And as they're done, they'll get posted to our site, which we are looking right now at a company called Gitbook. Gitbook allows people to comment, but it locks down the editorial capacity to people with the privileges. And this is what's coming out And we've got Bill Baumgartner and John Mayer working on a congenital and cardiac textbook as well. Now, once the publishers got wind that we were doing this, we can't buy any books anymore. They are extremely frightened of this technology and our desire to do something like this because they know it's sort of a death knell for their chokehold on knowledge. But what about other things? So what about future innovations? And this is where we're going to need a lot of help because this is the hard part. I told you we went after the low-hanging fruit. We went after the understanding and remembering. But there's all this stuff up here. This creating, evaluating, analyzing, and applying. That's the harder stuff to teach. And currently, as I said, we rely on the faculty to do that one-on-one using the apprenticeship model. But boy, it'd be nice to at least be able to provide some assessments of this. I've got some ideas. They're out there. They will take a lot more money. They will take a lot more time. They will take a lot more vetting to make sure that they're valid. But again, we don't need these to be hyper valid or hyper reliable because these are going to be assessments for learning, not of learning. But this is the sort of stuff we're going to need to work on for the next 10 years so we can improve the efficiency of this model. So in the end, as I started, apprenticeship works. I am not denigrating the apprenticeship model, but it's under assault. And I think we can streamline learning where apprenticeship is inefficient. I think we can certainly organize knowledge and incorporate new developments rapidly. We can provide increasing opportunities for assessments to aid in learning and retention of knowledge. And finally, I think we can eventually use assessments to guide and assist our learning overall. And then I'll just leave you with this, which I always think is appropriate. Thank you very much.
Thank you, R. This is a great presentation, very thought-provoking, and really apropos to where all of surgical education is today. I'd like to open it up for questions from the audience. Dr. Young.
Yeah, all right, that was both entertaining and profound. Thank you very much. Can you share with us maybe, if you have them, 2-3 tricks that you have employed now with your residents, stemming from your experience, diving deep into all this?
So the way we use this right now, we don't use the standard curriculum as it's pushed out. We have our residents rotating in different structures. We only have 4 because we're a 2-year program with 2 per year. So what we do is we assign the readings and we tell them to take the quizzes. We have a 2-hour session every Friday where we sit down in a small group discussion with a faculty member. What they'll do is they'll review the quizzes because you can go directly to the quiz the trainee took and quickly look at them and see how they did on those questions. And if there's a question that all of them got wrong, we'll stop for a while. And usually the first 30 or 40 minutes will be spent like that. And then I ask all my faculty to prepare cases based on the information that was covered in that knowledge. So if we're doing lung cancer TS05, which is essentially staging of lung cancer, I will give them a variety of situations and ask them how they would stage that individual and what stage this individual is and how that stage might change. And I will have the senior level, say general thoracic, teach the junior level cardiothoracic training. And vice versa, when we're on cardiac topics, I'll have the senior level cardiothoracic trainee train the junior level general thoracic trainee. And I'll ask them to grade the response of the other trainees. So it doesn't all have to be me talking to them. I'll engage them to teach each other. But I want it to be more a discussion of management and application of knowledge, because to me, that's the best use of my time, rather than pimping them on, you know, where does the PA branch, you know, what's the first branch of the right PA? I don't, that's, we call that Groundhog Day. All right, because you're doing the same stuff over and over. Every time a new resident comes in, you got to teach them the same thing again. I'd rather they do that on their own. These are 30-year-old men and women who are highly accomplished. They can learn anatomy on their own. They do not need me to stand over them and spoon feed it to them. But learning how to apply that information in planning an operation, that to me is where my expertise comes in. And when somebody made the comment that there's more attendings, if I give a test on medical knowledge, medical students blow away attendings, all right? But if I give you a test on decision making, attendings blow away medical students, all right? because our ability to parse out that knowledge and apply it quickly and rapidly comes over years of practice, where we're not memorizing stuff anymore. We stopped doing that a while ago.
A little bit about applying these types of applications, these concepts while you're in the OR. So there's, like you said, being interested in the so you got to get the case done. You
Yep.
have to, but it seems like you have to teach.
Yep.
And so if you could really, there's always a great opportunity in the OR in real time. You know, they already know what to look for.
Right.
So you lose that.
Yep.
But how can you maximize
Sure.
that OR time?
So I could give a whole nother hour lecture on teaching the OR because it's a separate area, right? But one problem with education in the operating room these days is, as I said, there's been this massive expansion of faculty, you know, compared to the number of residents we train. It's logarithmic on the faculty, it's geometric on the residents, all right? The problem is that residents don't train with a single faculty. It used to be that you'd go to the OR pretty much with the same faculty day in, day out. They knew you, right? They knew where your gaps were, and they could concentrate on those gaps. And they wouldn't waste time on the stuff they already knew you knew. But if you're in the OR with one faculty one day, and then you move to another faculty to do that case 2 weeks later, and they've never seen you do that case, they don't know where you're at, and they're going to start all over again. So one of the first things we need for surgical training is a method to share knowledge about where each trainee is in the case, so that faculty can quickly do a gap analysis, essentially, which is what you do in micro-teaching, right, in this rapid-fire teaching. The second thing is this assumption that we must teach them the entire operation every time we do it. That is a flawed assumption, all right? And I tell my faculty over and over, you don't have to teach them every nuance of the case in that day. In fact, they won't be able to comprehend that much information. So if you knew where they're at, so Vatt's lobes is perfect. You know, the vein is easier to take than the bronchus, which is easier to take than the artery, right? And so when I do a lower lobectomy, it's great. I mean, it's all in the right order. I'll tell them, I'll say, start with the vein. Let's see how you do. If you can power your way through the vein, great. I'll let you do the bronchus. But as soon as you start hitting a wall, I'm probably going to take over so we can keep the case moving along. But I'm going to push you right to the edge of your ability, and then I'll let you play there for a while and work, and then I'll get the case moving. Right? But the intent that you must learn the entire operation and every nuance of it from beginning to end when you sit down, that's a flawed assumption. All right. Yeah, you got, yes.
That's a fantastic talk. So the question relates to this expansion of knowledge. Your yellow box diagram where you start to eliminate the green.
Yeah,
It's a great thing. The issue comes up is that we go to education meetings, more and more yellow boxes are popping.
right.
So how
So we have a term for that.
You eventually will get to the point where you're going to have to start eliminating yellow boxes.
There's a great article that I could share called Diseases of the Curriculum. And that particular disease is called curriculomegaly, all right? Where the curriculum simply keeps expanding and expanding and expanding, right? Because everybody thinks their part is hyper important, and God, we couldn't get rid of that, you know, for God's sakes, you know. I've been teaching that for 40 years, you can't just dump it, right? But those are hard decisions that have to be made. And one of the benefits of being on the RC and on the board is the idea of bringing these groups together, all right? Because curriculum means the whole thing, right? But the board is really in charge of just developing the objectives, the final learning objectives. They don't want to get in the weeds of how you do the instructional design. They do only one assessment too, summative at the end. They don't want to get into the weeds about assessments, you know, training, PGY2 and an I6. They don't want to bother with that. The TSDA, that's what they want to bother with. They want that information, right? And the RC, well, they just want to make sure that it's fair and ubiquitous and there's no one program that's doing a bad job, right? They want to make sure everybody's held to the same standards. That all needs to come together. And those groups need to make those hard decisions. When I expand the box for TAVR, what gets carved out? You know, something's going to have to get carved out. All right, you can't just keep adding to it. Right? Or you just make the training longer.
Great talk. I was wondering if you could comment on the idea that there's this generation of teachers right now who are not very comfortable with the idea of the flipped classroom juxtaposed with the increasingly large generation of students who are growing more comfortable with it. How do you address that sort of gap?
With education.
You know, one of the things we have to talk about is how do we teach teachers to teach? And how do we teach
The classic model of training a teacher in surgery is similar to the idea that if you graduate kindergarten, you are now qualified to teach kindergarten, which is a pretty flawed assumption. There is enormous skill required to teach. Right? I think you know the expertise model, right? When someone, who's ever trained somebody, a kid to drive a car? Who's ever gone through that, right? Then you've seen the 4 models of expertise, right? When they first start, they are unconsciously incompetent. They do not know what they don't know, right? You put them in the car and you say parallel park, and they're like, what is that? Is that where all the cars are right, like next to each other? They don't even know what it is, right? After they've done it a little while, they become consciously incompetent, right? That means they're like, oh yeah, I tried the parallel park. I suck at it. I can't do it. You know, I think there's no way, right? Then after a lot of practice, they become consciously competent. That's where you watch them and you can see them thinking while they're turning the wheel. You know, they're looking at the wheel, they're looking this way and then this way, right? And you can see their brain like thinking through the steps to parallel park. And then after many years of practice, they become unconsciously competent, right? They're listening to the radio, talking to their friends, and parallel parking all at the same time, right? The problem is that most of the educators in CT surgery are unconsciously competent. They forgot the steps involved to do the things that they do routinely. But they're teaching people who are unconsciously incompetent, who don't even know what it is they don't know. So an expert teacher is somebody who can move effortlessly between unconsciously competent and consciously competent and break the steps back down, identify where the gap is in that specific learner and teach to that gap. That's a skill that you have to practice. That is not something that is inherent or a talent by any means. And so yeah, the argument is our educators do need it. And I see a time in the future where not everybody gets to teach. That you will have faculty at academic centers who are assigned to teach, and they will be the ones who get the residencies. The rest of you will do research and clinical practice at a high level, and that's fine. There's nothing wrong with that. Not everybody gets a lab, right? Not everybody should have a lab, right? And not everybody should teach.
You want to put a quick plug out for some of the courses that are out there for educating the educators?
So the American College of Surgeons is probably one of the best ones. And you don't need a master's degree to be an expert teacher. That's the other thing, all right? I would encourage you to apply to the American College of Surgeons, the ACS course, the Surgeons as Educators. They also have shorter courses at the meeting. I know that they do 1-day courses and 1.5-day courses. We ran the Educate the Educators course for cardiothoracic surgery with the recent transition of the Joint Council to the STS. That's on hold for a little while, and I'm in charge of the workforce that took over many of the sort of substantive activities of the Joint Council. My feeling is that that should probably reside with the TSDA and they should run with that. But we will bring that back eventually, maybe do it for program director or something like that.
Well, thank you very much.